Now coming on to another very important topic, that is amputation. Although it's a very dreadful word, but sometimes it's the most important surgery you have to perform, because saving life is more important than saving limb of the patient. We will briefly discussing its indications, its varieties, what are different types of it, and then amputation at the sites of election, that is other than the usually the most commonly performed sites which may be required at times in a certain circumstances. Now, what is an amputation and what are its indications? Dead or dying limb. For example, there is a peripheral vascular disease which accounts for almost 90% of the amputation. A patient has a Burgess disease, a patient has a diabetic nephropathy along with the diabetic polyneuropathy. This may be resulting in increased incidence of amputations. Why? Because they usually have a severe trauma, burns, and frostbite is usually the classical indications for. Sometimes you may have to perform amputation as the first surgery rather than doing any reconstructive work. Other is dangerous. For example, if there is a malignant tumor, for example, there is a chondrosarcoma of the hip joint. You cannot just leave that chondrosarcoma over there. You have to do something about it. But if it's involving the area where actually the hip joint is involved, so we may have to go for some kind of a hip disarticulation or even a pelvic amputation, which can be, although which may not be able to, we may not be able to salvage the limb at times. Crush injury, which could be to this, or it could be a damn nuisance. Now, these are classical 3Ds, that is a deadly, a dying, or dangerous, or it could be damn nuisance. For example, if there is a pain or a gross malformation, there is a recurrent sepsis or a loss of function. For example, patient had nerve injury or neuronal injury in which this limb is now a flail limb. He or she actually cannot use it for walking. Then there is no point of keeping that limb, which is actually a flail limb. Then it's better to amputate that limb and put a patient on a prosthesis so that he or she can properly walk. Or for example, in simple chronic osteomyelitis of tibia or femur can be a disaster as well. It can take years and years to correct. And sometimes even after 5 to 7 years, it's not completely curative. Then for the patient who has been suffering from chronic osteomyelitis for so long, then it could be really debilitating for the patient's life in a general. So it's better to give it an amputation and give him a prosthesis so that he or she can have at least a normal life with prosthesis rather than having to deal with that kind of a limb, which is actually more of a damn nuisance for him or her. But then again, this decision for amputation has to be decided by 2 consultants. Whether this patient needs amputation or not, that has to be decided by at least 2 consultants who are expert in at least one of them has to be a vascular surgeon. Now coming to the varieties. This could be a simple provisional amputation, wherein the limb is amputated at the distal most part. Skin flaps usually are used to cover the cut tissues, and re-amputation is actually performed. Definitive end-bearing amputation includes when the pressure borne through the end of the stump, that is, you fit, for example, below knee amputation. Our scar must not be terminal, as you can appreciate over here, because if the prosthesis is going to fit over this area, then it's going to affect the scar over here. Therefore, you need something, a prosthesis which can fit around this area. The bone end may be solid, that is, for example, it may be weight bearing, maybe on the distal part of the femur or the proximal part of the tibia. It could be through knee or it could be Syme's amputation. Usually, although it's rarely done in adults, but in children, through knee surgery is a very good option because we know that bones are going to grow. So if we are cutting it off in the mid tibia or mid femoral level, then eventually this femur is going to grow and come out of the stump. So there is always a problem. Through knee means that as at least the joint section actually through knee amputation would result in this problem, that it will resolve the problem of bone coming out of the stump eventually and may need refreshing of the amputation. Now coming to the definitive non-end bearing amputation. These are one of the commonest variety, and almost all upper limb and most lower limb amputations include non-end bearing amputations. The weight is not to be taken at the stump end, that is usually taken by the, and therefore the scar can be terminal. Now, what are the different sites of amputation at which this can take place? For example, if you see, this is the example of a lower limb. This could be supracondylar, it could be above the condyles, or this could be at the transfemoral level. An ideal stump is around 10 to 15 centimeter above the knee joint in above knee amputation and transfemoral amputation. But at times, if for example we are performing that for some kind of a cancer surgery, or if there is some Ewing sarcoma, and then we cannot just do this surgery and make it sure that spare some kind Ewing sarcoma over here, then we probably have to go above and make it sure that all the sarcoma is actually taken out when we are performing the amputation. Ideal for usually the transtibial or below an amputation is actually 8 to 10 centimeter below the knee joint, but that is again, it's if it is possible. If the tissue is necrotic above that, and if there is not enough tissue available, then we may have to go up or near towards the knee joint. Other option is disarticulation, that is the through knee. Through knee is a disadvantage in children, because when the limb is going to grow, it's not, the stump is actually not come out of the prosthesis, and will not require refreshing later on. So that is the lower limb amputation are mainly done for the ischemic disease. Doppler indices usually determine the amputation level, and transcontinental oxygen tension as well. Usually if ankle breaker index is, normally it's more than 0.9, but if it is less than 0.45, then it is an indication for surgery. And transcutaneous oxygen tension, if it is less than 30 millimeter of mercury, then means most likely this limb is quite ischemic and would require some degree of amputation. Usually knee joint preservation is indicated, but if it is not possible to preserve knee joint, then we may have to go for above knee amputation or transfemoral amputation. Then what are the principles or techniques of amputation? Then the use of tourniquet is done so that there is minimal amount of blood loss. Skin flaps are cut in such a way so that they can be helpful in covering the bone adequately. Then combined length is really 1.5 times the limb width. That is how you cut the flaps. But then again, depending upon whether how much tissue is available, there is high degree of variation on case-to-case basis. Equal length anterior and posterior flaps are for the upper limb. Division of the muscle is actually done distally. Easy anchorage of the suture is possibly because we have to go for myodesis. That's basically the muscle flaps which we are using to cover the bone. We have to anchor it to the bone actually in the form of myodesis. And then division of nerves is done in such a way that these nerves actually trunks are tracted down, and then once they're cut, so they're cut in such a fashion that they rock back in upwards, so that actually eventually this phantom limb syndrome can be prevented. Because if the limbs would be present over here in and around the stump area, they will regrow and produce a phantom limb syndrome. So usually the procedure of the nerves is such that they are caught, they are pulled down, and when they are cut as high as possibly, so that they actually retract back so long back, therefore they do not produce this phantom limb syndrome. Then bone saw can be used at proposed level, but we have to remember that bone has to be beveled properly. Therefore it does not need to have any edges which can damage the muscles later on, because that bone will be covered by a thick muscular flaps. So transtibial amputations. Usually tibia is usually beveled, then smooth rounded counters are created so that they do not then the tibia does not damage the muscle area. The fibula is cut actually 3 centimeters shorter. Why? Because actually otherwise if the fibula can regrow and produce a painful stump. Main vessels are tied, and removal of the tourniquet is done. Once we know that we have tied the main vessel, we have to look for the bleeding points. If there is any still bleeder out there, we can tie it up, or if there is some degree of small bleeders which can be cautery to secure the hemostasis. Once we are done with that, then we go for the basically bleeding joints are either ligated or cautery for hemostasis, and then we can go for the nerves and other areas. And once we are done with the amputation, we can suture back that myocutaneous flap over the bone and eventually suture the skin back for the aftercare. What is aftercare? Actually, hematoma formation has to be evacuated if it is possible, and usually hematoma formation does occur at times, and if it occurs, it has to be evacuated. But we usually restore hemostasis quickly because That is why we want to prevent metama formation. Other option is gradual compression stump stocks, which are actually readily available. That is to shrink stumps and produce conical limb end, which is usually visible, so that this can easily fit back into the prosthesis. Then muscles exercise of the joints are if for example this patient has undergone below knee amputation, then we need to remember that okay, yes, he or she does not have a limb, but knee joint and hip joint are intact, and movements of the hip and knee joint has to be done so that there is no contracture development later on. In this section, we have briefly gone through what are the different types of amputation and what are the indications. And usually the most common indication is a deadly limb, if it is highly dangerous for the patient, or if it is damn nuisance. If these three indications are met, probably the amputation is a very good option for the patient first up, rather than for any reconstructive surgery. Thank you very much. Keep watching sqadia.com.